From this slide, we'll talk about the causal inference in epidemiology. We'll talk from the association to the causations. When we talk about the causality in epidemiology, it is often said that the epidemiologists only study the association between exposure and disease. Well, nothing can be more wrong about this, because we start from the association, but we aim to find out the causations. So let's first start from the association. We're measuring about the association, and we will talk about different types of associations. The most common way to measure of the association is by the use of the statistical measurements of comparison. Standard measures include the rate ratio, odds ratio, the measure of difference in rates such as the attribute rates. We test to see if the association or difference is most likely by chance statistically, and we describe this as the statistical insignificance of the associations. We have discussed several common measures for the association in prior lectures. However, if the statistical significance exists, for example, the p-value is less than 0.05, we cannot simply make an inference that the exposure is the cause of the outcome. First, you need to consider the size of the sampling error. What does p less than 0.05 mean? Assuming equal to 0.05, that means for this study, the probability of that result of the study is reliable for 95%. And there's also 5% of probability of that is caused by sampling error or by chance. When making this calculation, the precondition is that the design, the conduct of the study, and analysis for this study are perfect. Almost no study is perfect in either design or conduct if the possibility of the sampling error is very limited. Then we may put more consideration to the association. We recognize that the association may be specious non-causal. One our goal is to interpret the evidence as to whether the association is causal or another explanation is more likely. Let's first take a look at this very familiar table of fourfold table that was described usually in the cohort study and in case control studies. So if it is a retrospective case control study, then we can see we organize this as the odds of the disease we want to calculate, while we actually are comparing the proportion of the disease in the disease what's the proportion of the exposure, and compare with the those without disease what is about the exposure of the probability. While in the prospective cohort study, we will start from the exposure that within those who are exposed, what is the probability of having a disease, and compare with those in the unexposed group, what is we will think about what is the probability of the disease. So, if there's the probability of exposure is different for case control study, or the probability of having a disease in the future is different in the cohort study, then the association may be between the exposure and the disease is significant. So, but even if that is a statistical significance, is this association is a biological relevance? Then we need to consider more about this. Actually, even though it is a statistical significant, any of these statistical significant results for the association may be caused by the real cause or bias or even chance. We need to consider about the sampling error around this statistical significance, and also think about probably the finding of just a chance finding. An association is present if the probability of the occurrence of an event or characteristic or the quantity of a variable depends upon the occurrence of one or more other events, the presence of one or more other characteristics, or the quantity of one or more other variables. The association between two variables is desirable as a positive when higher value of a variable are associated with a bigger value of another variable. In a negative association, the occurrence of a higher value of one variable is associated with lower value of other variable. Associations can be broadly grouped under two headings: the symmetrical or non-causal and asymmetric or causal associations. The definitive condition of asymmetric association are direction and time. Independent variable x must cause changes in the dependent variable y. The causal variable must precede its effect. The presence of certain criteria increases the likelihood of a true causal relationship, but only essential criterion is that the cause must precede the effect. There are two types of this kind of symmetric association: the direct association and the indirect association. For direct association, it has direct associated, for example, not via a known third variable, such as A directly associated with B. An indirect association means two types are distinguished, as shown in these figures. Effect C is associated with disease A only because both are related to the common underlying factor B. Alteration of effect C will not produce. So it has been suggested to avoid confusion with the alteration meaning of indirect association. This cause type also should be called as secondary association. And in the right side of the figure, effect C is associated with disease A by means of intermediate or interval factor B. Alteration of effect C would produce an alteration in the frequency of the disease A. To avoid confusing, this type should be called indirect causal association. Spurious association is another term that preferably avoid used with different meaning by different authors. Spurious association may refer to artifactual, fortuitous, and false secondary, or to all kinds of non-causal association due to chance, bias, failure to control for extraneous variables, confoundings, etc. The direct and indirect associations can be shown in this figure. We can see in the left side, a direct association means the characteristic under our study can directly associate with the disease, while indirect association mainly due to the confounding effect. That is, for example, in the right side of the figure, factor X was associated with both the characteristic under study and the disease, while the observed association between character under study and the disease was indirectly through the factor X. An actual example of this direct and indirect association can be shown using the example of coffee consumption and pancreatic cancer, which if we assume that there's a direct association, we will consider that coffee consumption will increase risk of pancreatic cancer directly. While in the indirect association assumption, then coffee consumption is actually associated with the smoking, and the association between coffee consumption and smoking is real, while the association between smoking and pancreatic cancer is also real. But we also observe the association between coffee consumption and pancreatic disease, and this association is indirect. We also call it a secondary association through the association with smoking. Besides the asymmetric association, there's also symmetrical association. Association is non-causal, or if it is symmetrical, as in the statement like the P equals to I multiplied by D. P means the prevalence equals to the incidence times the duration. This is a non-causal, non-directional expression of the mathematical relationship. Therefore, this is called a symmetric association. Now let's come to the question. If we already find out some association, for example, suppose we determined that exposure is associated with disease, such as environmental exposure, genetic background, or combination of both are associated with the disease or outcome. How do we know if the observed association reflects the causal relationship? To identify whether association is actually a causal relationship, we will need several of the research methods. As we have shown in here, And as we have been taught in the previous lectures, we can have different types of epidemiological studies trying to find out whether the association is causal. First, we can use the clinical observation or available data from ecological or cross-sectional studies to generate a hypothesis of the association. And we will then use the case control or cohort study to test the hypothesis. And only by the final step of a randomized clinical trial that will verify this hypothesis. And through these methods, we can to some extent make sure that this association is causal. Let's take an example to see how we discover the causes for retrolental fibroplasia. Retrolental fibroplasia is today's principal cause of blindness in children of preschool age, exceeding all other causes combined. The disease occurs in infants of low weight at birth, commonly those born prematurely. The incidence of the disease is rising at an alarming rate. While vitamin E deficiency, corticotropin deficiency, the use of cow's milk in place of mother's milk, and improper oxygenation have been suggested as etiological factors, but the cause remains a mystery. As the retrolateral fibroplasia often happens with a high incidence in institutions in which maximal care is given for the premature infant, many people consider it as a very rich people's disease. Although retrolateral fibroplasia is predominantly an American disease, cases have been reported in Canada, in Denmark, in England, in France, Spain, Sweden, and Holland. Generally speaking, the lower the birth rate and the greater the prematurity, the greater the incidence. In multiple births, the lighter and weaker infant is more liable to have this disease. So, in order to discover the causes for retrolateral fibroplasia, there are several studies that have been performed. First, there are some of the case control studies using the retrolateral fibroplasia babies as the cases, while the controls are the normal babies. And then they compared the probability of the dosing days, the bassinet, the days, and the concentration of oxygen for these babies. And they found that the longer the nursing days, the longer bassinet days, and the higher concentration of oxygen was associated with retrolateral fibroplasia. Next, the scientists performed a retrospective cohort study to find out whether there's a relationship between oxygen inhalation and the retrolateral fibroplasia. And they actually found that in the patients in babies with hyperoxia, which is the number of 123, they have an incidence rate of 80% as retrolateral fibroplasia patients, while in the regular group only 6% of the incidence rate. And comparing these two results, we can see that oxygenation is associated with retrolateral fibroplasia. To further confirm and verify this hypothesis, we can see in the next, they have performed an experimental epidemiological study to test the relationship between different doses of oxygen and retrolateral fibroplasia, in which we can find they have separated the babies into two groups, one treatment group, one is a control group. In the treatment group with 28 babies, they have discovered 17 retrolateral fibroplasia patients, corresponding to the incidence rate of 60%, while in the control group it is only 16%. So these results have confirmed oxygen as a cause of retrolateral fibroplasia.